Bismillahirrahmanirrahim. I'm Dr. Walid Ahmad. I'm the Senior Registrar at the Department of Psychiatry and Behavioral Sciences at Peshawar Medical College and Mercy Teaching Hospital, Peshawar. Today we will discuss eating disorders, which are disorders characterized by abnormal pattern of eating and which are related to concerns about body weight and shape. And we will also shed some light on the related feeding disorders. So uh, feeding disorders are related to uh, these involve abnormal eating or feeding behaviors that are not explained by another health condition and or not developmentally appropriate or culturally sanctioned. So this is important to keep in mind. Abnormal feeding can be the result of a medical condition, for example, patients with Kluwer-Bucy syndrome. Um, they put just about anything in their mouth. Patients with severe depressive disorders stop eating or reduce food intake, or patients with schizophrenia, they drink excessive amount of water. Similarly, culture or development also has an impact on the eating pattern. For example, um, people in China would eat wild animals. People in India um, are more likely to be vegetarian, some completely vegetarian, fasting and avoiding to eat pork meat is also these are also variations of eating behavior, cultural variations of eating behavior. So anything like this would exclude um, feeding and eating disorders. Eating and feeding disorders are primary abnormalities of feeding and eating behaviors. A little distinction needs to be made between eating disorders and feeding disorders. Eating disorders are, in addition to the abnormal eating behavior, characterized by preoccupation with food and concerns about body weight and shape. This, these concerns about body weight and shape and a preoccupation with food, it's not present in patients with feeding disorders. These are behavioral disturbances that are not related to body weight and shape. Not related to body weight and shape concerns. For example, eating of non-edible substances like chalk, clay, soil, etc. and pica, or voluntary regurgitation of food. Regurgitation means the intentional and repeated bringing up of food back to the mouth, which is then sometimes re-chewed and re-swallowing. Re-chewing and re-swallowing means rumination, refers to rumination, and it is these behaviors are the characteristic of rumination regurgitation disorder. So the common eating disorders include anorexia nervosa, bulimia nervosa, and atypical eating disorder. Anorexia is the most severe form of eating disorder, and bulimia, which is largely the same as anorexia nervosa, is actually slightly more common than anorexia nervosa. The most common one among these eating disorders is atypical eating disorder. Among feeding disorders include restrictive food intake disorder, binge eating, rumination, regurgitation, and pica. In restrictive food intake disorder, as the name suggests, patients they restrict their food intake to the level that damages their health. Binge eating disorder is characterized by repeated episodes of binges. Binging episode means a distinct episode, period of time during which the patient or the person has a loss of control over their eating behavior, a feeling of loss of control over their eating behavior, and during which they eat a large amount of food and they cannot stop. They have a feeling that they cannot stop eating. So again, they have an feeling of loss of control over eating behavior. They eat a large quantity of food and they have a feeling of inability to stop eating. So that's an episode of binge eating, and repeated binge eating episodes characterize binge eating disorder. Rumination and regurgitation. So we already defined regurgitation, which is the intentional bringing up, intentional and repeated bringing up of food back to the mouth, uh, which was already swallowed, and retrieving and re-swallowing that food is rumination. So rumination regurgitation disorder is characterized by repeated rumination and regurgitation, as the name suggests. In pica patients, usually children, they eat non-nutritive substances or substances with um, which are not edible, inedible or non-nutritive substances. So first we will discuss the common eating disorders, anorexia nervosa and bulimia. But before that, eating disorders, these are characterized by an overvaluation of weight and shape, such that these patients judge their self-worth in terms of body weight and shape, um, and by their ability to control these. They measure their self-worth in terms of body weight and shape and their ability to control these. And these patients are also preoccupied with eating, and because of that they start to develop abnormal eating patterns and the associated compensatory behaviors. Compensatory behaviors include behaviors intended to reduce weight gain, and these could be um, the ones to reduce consumption of energy, like fasting or food restriction, those that increase energy expenditure, like strenuous exercise and purging behaviors, which include self-induced vomiting, misuse of laxatives and enemas. These two are used to induce diarrhea, and of course self-induced vomiting is obvious. They do it with finger down the throat or with the syrup epicac. So these are purging behaviors. Now these behaviors eventually lead to a long list of medical complications that we will discuss. Okay, so the ideas and the central sort of psychopathological um, disturbance in patients with anorexia and other eating disorders is an overvalued idea. An overvalued idea is something between a delusion and an obsession. A delusion is a belief, it's a firm belief that is held on inadequate grounds. They don't have any logical, or it is unexplainable. They don't have any logical explanation for their belief. They don't have any sort of logic or any evidence for their belief, why they believe in what they believe. For example, someone might believe that their intestines are rotten, and because of that they won't be eating food, and it is a fixed or unshakable belief, which means that you cannot change or modify their belief with the help of logic or reason. An overvalued idea is a similarly firm, sustained belief, which is also either false or exaggerated, but it is slightly explainable by the person's religious or cultural or educational background, social background, and it is slightly amenable to argument or logic. So these two factors differentiate an overvalued idea and a delusion. Why the idea in patients with eating disorders is an overvalued idea, we will discuss that. But before that, obsessions are recurrent, persistent thoughts, impulses, or images that enter the mind despite efforts to exclude them. So these are intrusive thoughts, and they are considered false by the patient, and patients act to undo them. For example, someone might have an intrusive thought that their hands are dirty, and because of this intrusive thought they repeatedly wash their hands. Now, these patients wash their hands not because they believe their hands are dirty, but because they want to get rid of the intrusive thoughts. So anorexia nervosa is characterized by significantly low body weight, and this is the central feature of anorexia nervosa. And it also helps differentiate anorexia nervosa from bulimia nervosa, because the rest of the criteria between anorexia and bulimia, they overlap. This is the only feature of anorexia which is not present in patients with bulimia nervosa. By definition, the weight is below 18.5 kg per meter square. Previously, it was 17.5 kg per meter square. Not below 18.5 kg per meter square is enough to meet the diagnostic criteria for anorexia nervosa. And in children, the BMI has to be lower than the fifth percentile for age. So, significantly low body weight, and also remember that rapid weight loss, for example a 20% weight loss in under 6 months duration, could replace the diagnostic criteria of 18.5 kg or below fifth percentile in children, that criteria. It is also associated with compensatory behaviors, which we already discussed, which include behaviors aimed at reducing weight gain. That could be to increase the energy expenditure, like strenuous exercise, behaviors to reduce energy intake, like restricting food, and purging behaviors, which include self-induced vomiting and misuse of laxatives and enemas. There is also an intense fear of gaining weight and becoming fat, and a strong desire to be thin. Fear of gaining weight and becoming fat, and a strong desire to be thin. And there is an undue influence of a body weight or shape on self-evaluation, and there is a lack of recognition of seriousness of low body weight. So their body weight may be much more below the normal BMI, but they still think that they're either normal, or even sometimes they still perceive themselves to be fat. So these are the central features of anorexia nervosa. Two subtypes of anorexia nervosa are described depending on whether the patient has involved in binge eating and purging behaviors. So if the person has regularly engaged in binge eating or purging behaviors, which include self-induced vomiting, misuse of laxatives and enemas to induce diarrhea, so we would call that a binge eating or purging type. And if these behaviors are not um, the patient does not involve in these behaviors regularly, so we would call it a restricting subtype. Anorexia nervosa, it was first described by Louis Victor Marcy in 1860, but he did not name it. It was first named by Charles Lessig in 1873 as Dila anorexie hysterique, and then finally in 1870, William Gull named it as anorexia nervosa. The onset of anorexia nervosa is usually between 16 and 17. It's important to note because a later age of onset is associated with a poor prognosis, as well as an earlier age of onset. So keep in mind that the usual age of onset is between 16 and 17, and that it is rare after 30. It's also important because if someone has symptoms of anorexia nervosa after the age of 30, we might uh, have to look for other causes of anorexia nervosa or the symptoms of anorexia nervosa. Incidence, which means the number of new cases in a specified duration of time, ranges from 0.4 for studies conducted in the United States to 4 for Swedish studies per 100,000 population per year. And it is much more common in females, for which the incidence rate is 15 per 100,000, and compared to males in whom it is only 2 per 100,000 per year. Similarly, the prevalence rates are much higher in females, about 270 cases per 100,000 population in females. Prevalence means the number of cases in a population at a given instant in time. There is also a subtype of prevalence which is period prevalence, but here we are talking about point prevalence. Previously, it was believed that, or some studies had shown that anorexia nervosa is 10 times more frequent in females. But according to recent community studies, the male to female ratio is 4 to 1, which means it is 4 times more frequent in females compared to males. However, in clinical practice, only 5 to 10% of the cases are male. So, in clinical practice, male patients are highly underrepresented. And the most common explanation, or the most common reason, is a bias on part of the clinician that it is considered a disorder of females. And so, it is easy to be missed in male patient. So, keep that in mind, and it needs to be screened in female patients, male patients as well. Anorexia nervosa is much more common in the upper social class, and it is also common in occupational groups concerned with weight, for example, ballet dancers or gymnasts. Um, it's also important to keep in mind that it is much less common in developing countries like Pakistan, but um, we can expect that the incidence is rising, and the cult of thinness in westernized societies is the most likely cause of this social drift or increase in uh, incidence of anorexia nervosa in developing countries. So in the future, we can expect higher number of cases in Pakistan and such developing countries as well. The etiology, or the causes of anorexia nervosa, are multiple. uh, Biological and psychosocial causes have been proposed. The first studies on the effects of starvation were carried out in during the Second World War. These were termed as the Minnesota experiments at the University of Minnesota. And in this study, in these experiments, 36 healthy volunteers were recruited who were starved for 6 months, and it was then followed by 3 months of rehabilitation and 9 months of further monitoring. These patients, among other effects of starvation, they also started to develop anorexic symptoms like obsessions with food, hiding food, and binge eating. So we may conclude from these studies that the behavioral and mental symptoms of anorexia nervosa could also be the effects of starvation itself. Um, Among biological explanations, hypothalamic dysfunction, disordered neurotransmitters, and genetic factors are important. Patients who have lesions in the hypothalamus have been shown to have symptoms of anorexia nervosa. Remember that the satiety center of the brain lies in the hypothalamus. Disordered neurotransmitters, especially an imbalance between serotonergic and dopaminergic mechanisms of the brain, has also been shown. Serotonergic systems, an increase in serotonergic system has been shown as well. But um, we could simply say there is an imbalance between serotonergic and dopaminergic mechanisms of the brain. Genetic factors are very important. Anorexia nervosa is about 10 times more frequent in the female siblings or sisters of probands or identified cases of anorexia nervosa compared to its incidence or prevalence in general population. Uh, so in family members, especially first degree relatives, its prevalence is high. Uh, Concordance rate in monozygotic twins is also very higher compared to dizygotic twins. Concordance rates means the likelihood of a disorder or a condition occurring in both of the twins. So if concordance rate is 50% for a condition, that would mean that if one twin has that specific condition, there is 50% chance in the other twin as well to have the same disorder. 50% of the times, both monozygotic or dizygotic twins are expected to have the same condition. So concordance rate in monozygotic twins is 56% compared to dizygotic twins. Monozygotic twins share a lot of genetic, they have almost the same genetic makeup, almost the same, and so compared to dizygotic twins. So we can say that it has a higher heritability, and based on the calculations, the heritability has been estimated to be around 76%. So keep in mind, and finally, it has a genetic overlap with conditions like obsessive compulsive disorder and schizophrenia. So genetic factors are important. It is highly heritable with a heritability of around 76%. In first degree relatives, the incidence is much higher than in the general population. And similarly, neurotransmitters and hypothalamic dysfunction. Various other psychosocial explanations have been put forth. For example, causes within the family, homeostasis. This is a relatively difficult concept to explain. Just keep in mind that the illness of the patient is sort of necessary for the proper functioning of the family. It's a very difficult concept to explain. I won't go into the details. Similarly, social factors are important. The influence of the media in which thinness is associated with models, um, and there is also peer influence. Fatness is undesirable while thinness is become highly desirable. So we learn this from the media, as well as there is a lot of peer influence involved. The personality factors involved in anorexia nervosa involve perfectionism as well as a low self-esteem. So these two, perfectionism and low self-esteem, these two factors in the personality of a person are also important for the causation of anorexia nervosa. A long list of complications could arise from anorexia nervosa. We will briefly go through these complications. So metabolic complications include dehydration, hypoglycemia, hypoproteinemia. These patients also often restrict their fluid, so that could cause dehydration. Hypoglycemia results from reduced energy intake and increased energy expenditure. Hypoproteinemia, which could result from uh, hyperproteinuria, that is increased excessive loss of proteins in the urine, as well as reduced production of albumin and other proteins in the liver. There are disturbances in cholesterol and lipid metabolism. There is hyperkeratinemia, high free fatty acid, and hypercholesterolemia. The liver is involved in the metabolism of these um, fatty acids. So these are, instead of being stored, their level rises in the blood. Metabolic electrolyte imbalances include hypokalemia, which is important because patients with anorexia nervosa are also at risk of developing cardiac complications like arrhythmia, and hypokalemia also causes arrhythmia. Magnesium, calcium, and phosphate levels are also reduced in patients with anorexia nervosa. Keep again calcium and phosphate in mind, as these put the patient at risk of developing osteoporosis. Cardiovascular complications include congestive cardiac failure, which may be evident in the form of peripheral edema and in hypotension. There is also rhythm changes are also prominent, which include bradycardia and QT prolongation. Um, so as we said, there is electrolyte imbalance, especially hypokalemia, which can sort of contribute to the rhythm changes. Decreased heart size and mitral valve prolapse are the structural deficits in patients with anorexia nervosa, unlike in most patients with congestive cardiac failure, in which there is cardiomegaly. These patients have a decreased heart size. Neurological abnormalities include abnormalities in the electroencephalogram, which also correlates with the occurrence of seizures or epileptic fits. There is a pseudoatrophy in brain on brain imaging, which is because of increase in ventricular brain ratio. So the ventricles, they appear dilated compared to the parenchyma of the brain. So there is an apparent or pseudo atrophy on brain imaging because of this relative increase of ventricles of the brain and loss of the parenchyma of the brain. Peripheral neuropathies and autonomic dysfunction can also occur. These are made, remember, the myelin sheaths of nerves in the brain as well as the peripheral nerve system, they are made from fat. So if there is loss of fat and energy, so we can expect such kind of complications. Endocrine abnormalities are also very important. Sexual hormones like gonadotropin, estrogens, and testosterone, their levels are reduced, which lead to amenorrhea in women and in men, a loss of libido. Amenorrhea, and previously it was a diagnostic criteria. It was so frequent that it was one of the diagnostic criteria of anorexia nervosa. And in many patients, it actually precedes weight loss. So this is very, very important in women and amenorrhea. It is no more one of the diagnostic criteria, but keep in mind that this is very important and often it precedes the development of weight loss in patients with eating disorders, anorexia nervosa. Growth hormone is increased perhaps because due to starvation there is a stunted growth, and sort of this is a mechanism to balance the effect of that starvation and to reverse this stunted growth. The growth hormone is increased. Cortisol is a stress hormone which is released in most conditions of stress. It is also elevated in patients with anorexia. The level of T3 is reduced, but other thyroid hormone, including thyroid stimulating hormone T6 and free T4, these levels are unaffected and there are no clinical signs of hypothyroidism. This is known as an euthyroid 6 syndrome or low T3 syndrome. So these are the endocrine abnormalities. Hematological abnormalities include a hypocellular bone marrow. Hypocellular bone marrow means there is a lot of mitosis and reproduction of various blood cells, including white blood cells, thrombocytes, etc. They're in red blood cells. They are produced in bone marrow. So hypocellular bone marrow means the production of new cells has halted or reduced, and that is why we see thrombocytopenia, which means reduced number of platelets, and leukopenia, which means reduced number of white blood cells. However, there is a relative lymphocytosis. The number of lymphocytes, which are a specific type of white blood cells, is relatively increased compared to other white blood cells. Anemia is also present, which is sometimes normochronic, normocytic, but sometimes iron deficiency anemia. If there is deficient intake of iron, especially in female who are already at risk of developing iron deficiency anemia, so this reduced dietary intake of iron in meat and other products would contribute to the development of iron deficiency anemia. But sometimes it could be normochromic normocytic anemia. Remember, iron deficiency anemia is microcytic anemia. There is also inflammatory changes and immune changes are also present in patients with anorexia nervosa. ESAR or erythrocyte sedimentation rate is reduced, serum complement levels are reduced. So keep in mind that immunological changes are also present. Musculoskeletal complications include osteoporosis. We talked about reduced calcium and phosphate. So bone mineral density correlates with the interval of amenorrhea. Remember the effect of estrogen on osteoporosis and bone structure. It can be compared to the development of osteoporosis in postmenopausal women in whom estrogen levels are reduced and there is no amenorrhea, who are also at higher risk of developing osteoporosis. So patients with anorexia nervosa are at a similarly increased risk of developing osteoporosis and is finally having stress fractures. There is a stunted growth. We talked about it in relation to increased level of growth hormone, and finally there are muscle cramps, probably because of electrolyte imbalances, especially calcium and potassium. Remember the smooth muscle contraction process which involves calcium. Okay, obstetric, obstetric complications include complication in babies, which are low birth weight, miscarriage, and congenital malformation. Perinatal mortality is also increased if patients conceive before complete restoration of weight. So this is important from management point of view, that if there is a patient with anorexia nervosa, she should not conceive before she has restored her weight. During pregnancy, the energy requirements of the females they increase because of the fetus is growing, and so that leads to an increased demand of energy and other nutrients on the mother. And if she's already starving, so we can expect why the mortality rate would be increased in these patients. Renal complications include pre-acute or chronic renal failure, as a result of which there is reduced glomerular filtration rate. This renal complication, renal failure, could be the result of hypokalemic nephropathy. We already mentioned several times that there is hypokalemia. The level of potassium in the blood is reduced, which could cause a nephropathy. So it could be hypokalemic nephropathy or due to renal stones in these patients. Sometimes there is partial diabetes insipidus, which means there is a loss of liquids, and this could contribute to dehydration. In the start, one of the metabolic abnormalities was dehydration, and that dehydration was partly due to fluid restriction, but diabetes insipidus, in which the fluid loss through kidneys it increases, could also be the cause of this dehydration. And finally, there is proteinuria, which again could contribute to the low protein levels or hypoproteinemia, low protein levels in the blood. Okay. Other complications include bacterial infections. Remember, we talked about immunological disturbances, complement levels were reduced, as well as the inflammatory marker ESAR level was affected. So liver, which is responsible for the production of these immunological substances, there is dysfunction in liver, and so these patients are at increased risk of bacterial infection. There are also brittle hair and nails. Lanugo hair is present on the back of the trunk, which is the hair found on newborn babies, but in patients with anorexia nervosa, such type of hair may appear again. But it is not present in the normal locations where there are secondary sexual characteristics develop and the hair pattern of an adult develops, like in the axilla or pubic hair. That is spared. Lanugo hair is present on the back of the forearms or on the back. So management starts with investigations. We have already talked about these complications. Based on these complications, we may investigate the patients accordingly. Baseline investigations are necessary in all of the patients, which include complete blood count. Remember, On complete blood count, we can expect hypo anemia. We could expect anemia. We can expect leukopenia with relative lymphocytosis, thrombocytopenia, and serum electrolytes are expected to be disturbed. We talked about hypokalemia, magnesium, phosphate, and calcium, which are specialized investigations anyways, are also disturbed. Liver and renal function tests, we talked about reduced GFR and nephropathy, electrocardiography to identify any arrhythmia, any other mitral valve prolapse, etc. Chest X-ray would be important, blood glucose, because patients often have hypoglycemia, and they also have impaired glucose tolerance. Specialized investigations are those that we only obtain in patients in whom the earlier investigations or physical examination findings suggest the requirement for further investigations. For example, if there are signs of endocrine imbalance, stunted growth, amenorrhea, low libido, we can have hormonal assay, lipid profile, serum albumin and urine albumin is important if we expect hypoproteinemia and proteinuria, renal failure, serum creatine level correlates with abnormal lipid profile, calcium and phosphate if we suspect osteoporosis, echocardiography where the findings on ECG suggest the need for echocardiography, or there are signs of congestive cardiac failure like peripheral edema. Eating attitudes test. Psychological investigations include eating attitude test, CGI, which is the clinical global impression, hospital anxiety and depression scale, and HAM-D. Eating attitudes test is used to assess eating behaviors and attitudes that we talked about. Binging, purging behaviors, food restriction, increased energy expenditure, these types of, and abnormal eating patterns. Clinical global impression is a general test that we use to monitor the severity of any condition. It's a small test and we can use it in almost any condition. HADS or Hospital Anxiety and Depression Scale is a screening tool that we use in hospital and clinical settings. It's a self-rated scale to identify uh, anxiety and depression. Patients with anorexia nervosa are highly, so they have several comorbidities among which depression and anxiety, especially depression, is most frequent. So to identify depression, we may use HADS, HAM-D or Hamilton depression scale is used to measure the severity of depression. So these are psychological investigations that we may obtain. Okay, now about the treatment it begins like in the management of every condition, it begins with a good relationship with the patient or therapeutic relationship. And the basis of a good therapeutic relationship is listening to the patient and developing rapport, trying to understand their problem and their mind. And, and then we educate the patient and the family about the condition, the available treatments, the causes, prognosis, etc. Admission to the hospital may be required. There are other criteria for hospital admission, but some criteria include if the weight is less than 65% of standard, or BMI body mass index is below 13, there is a rapid weight loss, severe depression or suicidal ideation, or the outpatient care has failed. So we can use um, we can then admit the patient. Most of the patients are managed on outpatient basis. Okay, now weight restoration, it's the target for weight restoration is a compromise between a healthy weight and the patient's concept of ideal weight. Remember that these patients perceive themselves to be overweight or of normal weight despite having a BMI of say 13 or 15, grossly reduced weight. A reasonable target is to aim for around half or 1 kilogram per week. But you have to keep in mind that as the patient starts to gain weight, they become fearful. They are already fearful of gain weight, and this fear may increase with weight gain. Hypophosphatemia and the risk of cardiac failure has to be kept in mind. This hypophosphatemia often increases when we start weight gain. So hypophosphatemia, I wouldn't explain how, but it often increases. We call it a refeeding syndrome, and there is also a risk of cardiac failure when fluid levels are increased. The heart is already compromised. Heart size may be reduced. Um, there is a congestive cardiac failure, and so if we increase fluid overload, so cardiac failure may either occur or may worsen. Also beware of patient eating their way out of hospital with subsequent increase in guilt and feeling of failure. So for this purpose, previously we used rigid treatment regimes for patients, but these days rigid regimes are avoided because patients will become sort of non-adherent to your treatment uh, plan. So this has to be kept in mind. Psychotherapies include family-based therapy, CBTE or CBT enhanced, and self-help groups may also be of help to these patients. Family-based therapy is especially effective if there are causes within the family. We didn't go into the details of causes of eating disorders or anorexia within the family, but keep that there are some causes and which could be addressed with family-based therapy, but it also requires that the family is willing to take part in the treatment. CBT enhanced is a specific uh, modification of cognitive behavior therapy that is used with patients of eating disorders, especially anorexia nervosa. Okay. The Regarding the course and prognosis of anorexia nervosa, the Maudsley study was the landmark prognostic study on anorexia nervosa. They recruited patients with anorexia nervosa and followed them for 20 years. At the end of the duration, that is 20 years later, 63% had progressed well, which mean either recovered or had mild remnant symptoms, while 37% had poorly adjusted or had died. To be more specific, at the end of these 20 years, 15% of the patients had died. But this was crude mortality rate, which means that causes of death were not taken into account. In other words, crude mortality refers to all-cause mortality after a specified duration of time. So, 20 years later, the crude mortality rate was 15%. Prognostic Among the predictors of outcome, the good prognostic factors include short duration of treatment and of the illness. So if the patient has recently had these symptoms, he can expect a better recovery or quick recovery and a good prognosis. Inpatient treatment at early age. Remember the key word, notice the key word here is at early age. So if there is early treatment or early age treatment, we can expect good sort of recovery and finally preserved insight, because patients who have insight know they need treatment, they realize that they have an illness and they comply or adhere to treatment plans. So these are the three factors that predict good prognosis, while factors that indicate a poor prognosis include premorbid obsessive compulsive disorder, pre-menarchal onset, so onset before menarche in females, and onset when the patient is already adult. So we already said the usual age of onset for anorexia nervosa is between 16 and 17 years. Very early age of onset, like pre-menarchal onset in female patients, or onset when the patient is already adult, that would predict a poor prognosis, as well as pre-morbid OCD, which means the patient, when he develops or she develops anorexia nervosa, is already suffering from obsessive compulsive disorder. Patients who require hospitalization, which is also an indirect indicator of a severe illness, uh, would be a poor prognostic factor, as well as a low body mass index, which at presentation, which again is a marker of severity. Patients who require hospitalization, while patients who have a low baseline body mass index, these patients can be expected to have a poor prognosis. Now, bulimia nervosa is largely the same as anorexia nervosa. There are frequent recurrent episodes of binge eating. Binge eating, these behaviors are also present in patients with anorexia nervosa. But in patients with anorexia nervosa, the hallmark or the central feature is a weight loss. Here, the most characteristic or prominent symptom is binge eating, which are distinct. Binge eating episode is a distinct period of time during which the patient has a loss of control over eating, and they have a feeling of not being able to stop eating, and they eat a large amount of food during that period. They also have repeated inappropriate compensatory behaviors, which we again have already discussed, including behaviors intended to increase energy expenditure, behaviors to reduce energy consumption, and purging behaviors. There's also a similar preoccupation with body weight and shape as in patients with anorexia nervosa, but finally, there is marked distress and significant impairment. I'm sorry we did not talk about this criteria in patients with anorexia nervosa, but every disorder, psychiatric disorder, is only diagnosed if it causes marked distress and significant impairment. The individual does not meet the diagnostic requirements of anorexia nervosa. So if a patient can be diagnosed with anorexia, we would not diagnose bulimia nervosa. Anorexia takes the precedence. Notice weight requirement is not present in patients with bulimia nervosa. Avoidant or restrictive food intake disorder, as the name suggests, is characterized by avoidance or restriction of food intake to a level that um, causes damage to health. This restriction or avoidance of food intake, it leads to insufficient quantity or variety of food to meet the adequate energy or nutritional requirements of the patient, and eventually either significant weight loss or physical health, affects the physical health of the patient, or causes significant impairment in various spheres of life, like social, personal, occupational, or academic spheres of life. So that would be avoidant or restrictive food intake disorder. But notice that if a patient has a preoccupation with body weight or shape, which is one of the diagnostic criteria for bulimia and anorexia nervosa, which are eating disorders, that would exclude avoidant or restrictive food intake disorder. In patients with feeding disorders, uh, in this case avoidant or restrictive food intake disorder, preoccupation of body weight and shape is not present. Of course, if the restriction is due to unavailability of food, or it's due to another medical condition or mental disorder, just like we talked about previously, patients with severe depression will not eat or stop, reduce their food intake. Sometimes patients with schizophrenia may stop eating, medical conditions that lead to loss of appetite. So such condition would exclude avoidant or restrictive food intake disorder. The effect of a substance, for example, stimulant medications, they suppress appetite. That would also exclude the possibility of avoidant or restrictive food intake disorder. So keep this in mind. Binge eating disorder is a disorder in which the central feature is again frequent and repeated episodes of binge eating. This was also the central feature of bulimia nervosa. However, there are no compensatory behaviors as in patients with bulimia nervosa, and there is no preoccupation with body weight or shape. However, these binge eating episodes are experienced very distressing, and there is marked distress or significant impairment in various spheres of life. So that's binge eating disorder. Remember, it's uh, the hallmark of binge eating disorder is frequent episodes of binging, but without the preoccupation with body weight or shape, and no compensatory behaviors as in bulimia nervosa. Pica is a disorder characterized by the consumption of the persistent and repeated consumption of non-nutritive substances like clay or soil and or chalk, etc. And raw food ingredients like a large amount of salt or a large amount of corn flour. And these behaviors or this consumption of these non-nutritive substances and raw ingredients is persistent and severe enough to require clinical attention. And finally, it either causes damage to the health or puts the patient at risk of various infections or other complications like toxicity because of the ingestion of toxic substances. So that's pica. Finally, rumination regurgitation disorder is characterized by the intentional and repeated regurgitation of food followed by rumination or deliberate spitting out. So we already defined regurgitation and rumination as well. Um, these are the central features of rumination regurgitation disorder. Sometimes the food is spat out instead of being ruminated. These behaviors are frequent and occur at least several times per week, and they are sustained over a period of several weeks. And finally, the regurgitation behavior is not fully accounted for by another medical condition and does not cause diarrhea, vomiting, or nausea. And finally, it is only diagnosed after the age of 2 years. So that brings this lecture to an end. Thank you. If you have any questions, you can email me at dr.colleague@outlook.com.